What's going on, guys? I'm Jimmy and I'm a pharmacist here. And so I wanted to review this medical series called The Pit and just give a pharmacist perspective from a drug pharmacology perspective. And so this is a new journey for me. And so I just want to give people insight and education on why drugs are given in particular situations. And so, yeah, without further ado, sit back and it's going to be a long ride. And I'm going to try to discuss every scene that I think is relevant as far as the drug pharmacology is concerned. So this is my gaming setup, my virtual gaming room, and so you have everything here. My camera is here, but my screen is here, and so yeah, like, comment, subscribe. Holla at your boy. Let's get into it.
Awaiting ICU bed.
Hey, Doc.
And we all know Louis Cloverfield. Blood alcohol of 420 at 11 p.m.
I've been cutting back.
How is he still breathing?
That's a lethal dose for you and me. That's happy hour for Louis.
Sobered up, had 2 rounds of lorazepam.
Hold out your hands for me, Louis. Another 2 lorazepam.
On it. And a script for Librium.
It's good to see you, Louis.
All right, so I like this scene here. This is a good opening scene that I want to begin with drugs and why we're using drugs in this situation with this patient. And so you hear the first thing you see that the resident, he noted that this patient had a blood alcohol level of 420, which is certainly above the legal limit. And to people who don't drink, that is certainly is a lethal dose to kill us. However, for this patient, that's normal for him. And so you also hear the resident say, give him 2 of lorazepam. And 2 of lorazepam is very, very appropriate here. This patient is stable. This patient is not decompensating. And so 2 of lorazepam, 2 milligrams of lorazepam here is appropriate. And what this patient is undergoing or going through is something called acute alcohol withdrawal. And so this is very typical in this disease state. What I also would have liked to see here is that they would have gave him thiamine or vitamin B1. And so vitamin B1 is very important in this context, in this scenario, because chronic alcohol drinking definitely affects the way vitamin B1 is absorbed in your body. And so if you give vitamin B1, that can certainly reduce his risk of developing to something much worse, something called Wernicke's encephalopathy, which can then turn into Wernicke's Korsakoff, which can then turn into delirium tremens if left untreated or if not treated appropriately. And so this is a misstep on the script writer's part, not including the full spectrum of care when it comes to this disease state. And so 2 milligrams of lorazepam is used to control those acute symptoms associated with acute alcohol withdrawal, much like those agitation, those jerk-like reactions, anxiety, and things like that. And so why benzodiazepines are chosen here is because they target what's called GABA. They target those GABA receptors in the brain. GABA is your body's main inhibitory neurotransmitter. And so the purpose of that is to calm, relax, reduce anxiety, reduce your awareness, and things like that. And so when a person drinks alcohol chronically over a long period of time, alcohol enhances GABA. So the more you drink, the more your GABA levels increase with chronic use of alcohol. And so if a person abruptly stops drinking alcohol, it messes up the neurotransmitters balance. And so GABA is your body's main inhibitory neurotransmitter, and glutamate is your body's main excitatory neurotransmitter. And so under normal conditions, both these transmitters exist in perfect harmony on a balanced scale, right? And so if a person drinks so much alcohol, GABA will increase. And so naturally your body's going to try to, bring it back to harmony, bring it back to equilibrium. And so your body's going to try to increase glutamate levels in order to compensate. And so when a person abruptly stops drinking alcohol, those GABA levels drop, leaving you with excessive amounts of glutamate. And this can cause hyperexcitability, which means that your cells in your brain, your neurons can fire much easier than they would. And this is very dangerous because if they can fire off, decreasing that threshold, it can cause seizures, it can cause tremors, it can cause agitation, more so rapidly than a person who has normal levels. And so the thought behind this is if you treat a person acute symptoms with benzodiazepines by targeting that GABA receptor. You can reduce those acute symptoms like agitation, those tremors. You can effectively treat that along with other adjunct therapy like vitamin B1 to treat his thiamine deficiency. This person typically will get put on what's called a CWAR protocol, and this is just a screening tool to let healthcare professionals like myself and other doctors and nurses to assess the severity of the situation, and that way we can tailor our drug regimen to treat his specific case. And so for this particular scene, I would give it maybe an 8 out of 10 because they did treat him acutely with benzos, and then they also wrote for Librium. Librium or chloridase epoxide is also a benzodiazepine, but we use that in the maintenance phase. And so Librium has a much longer half-life than Ativan or lorazepam. And so that's why we treat his acute symptoms with benzos like Ativan. And then when we're trying to switch him to long-term therapy, we're going to switch him to Librium so we can dose it less times a day. And so that's the reason why, the resident wrote him a script for Librium, is to transition him into long-term maintenance therapy. And so I'll give this scene an 8 out of 10 simply because they didn't include the entire treatment approach when dealing with this patient as far as drugs are concerned. You certainly need thiamine in this situation to prevent Wernicke's-Korsakoff.
42-year-old male, Sam Wallace, blunt head with agonal respirations. Dropped down the T-tracks. Couldn't tube him, LMA in place.
Suicide attempt?
Rescue. He's a good Samaritan. Took a spill helping a woman who fell off the tracks. She's right behind us.
Okay, trauma 1, go ahead. Come on.
Woman fall from T platforms, good vitals, no head injuries. Degloving injury, right lower leg with open fracture dislocation of the ankle.
Oh, okay, trauma 2, let's go. How we doing, ready? Okay, here we go, ready? 1, 2, 3.
Good breath sounds bilaterally, but we need to protect his...
Apparently, he jumped down to save the lady. When he climbed back up, he slipped, fell back and hit his head.
Thanks.
It's more of an RT procedure. Mel, right? I need you on the E fast. Pupils, 4 millimeters, and reactive.
Okay, that's encouraging.
What do you want for meds? 120 ketamine, 80 of rock.
All right, so here's a good scene here for me to stop it and explain what's going on with this patient. This is a TBI patient, a traumatic brain injury patient, and you hear that the EMS person said they could not tube him. And so the emergency team personnel, their first priority is to try to stabilize the bleed and intubate this patient at the same time. To facilitate tracheal intubation, you hear that the resident say she wants 120 of ketamine and 80 of rocuronium, or what she called it, rock for short. And so I think this is very appropriate with this scene here. And what they're trying to accomplish is something called RSI, or rapid sequence intubation. And with a TBI patient who is unconscious and unknown GCS, and so we're trying to make sure this person's airway is intact, and so we don't further cause any more damage to this person and increases mortality. And so the choice of drugs, I would say, is very appropriate for this scenario here in the emergency setting. And here's why. She chose ketamine for her induction sedation agent, and that's totally okay, simply because ketamine provides you these multiple benefits with the mechanism of action. And so ketamine provides you pain relief, which is your analgesia, and then it also provides you sedation, both pre and post sedation. And so ketamine also raises your blood pressure by releasing catecholamines. And so in unstable patients with cardiovascular instability, ketamine certainly is a good option in this choice, right? It can increase your blood pressure slightly, and then it also provides the patient pain relief and sedation with the appropriate dosing. And she said 120 of ketamine, assuming this is a 70 to 80 kilogram patient, the dosing is very spot on. Depending on your hospital's protocol, the dosing should be around 1.5 to 2 mg per kg. And so the dosing is very spot on with this scenario. And I like the choice of ketamine here, albeit you do have other options in rapid sequence intubation. You have etomidate, you have propofol, and you have midazolam, certainly. But albeit ketamine and etomidate are your two most used induction agents. And so I like the choice of ketamine again for those benefits. And she said rocuronium. She said 80 of rock. or rocuronium for short. Rocuronium in this scenario is simply the paralytic. Its main job is to paralyze, not sedate, not treat pain. Its main action is to paralyze this patient, and so that we can facilitate tracheal intubation. And so rocuronium is in a class of medications called non-depolarizing neuromuscular blockers. And so out of all non-depolarizing neuromuscular blockers, rocuronium has the best PK-PD profile. And so what this means is that out of all your NMBs in the same class, rocuronium has the fastest onset, and it doesn't last as long as we want it to. Rocuronium has a relatively 30 to 40 second onset, and then as far as duration of action, it lasts about 30 to 40 minutes. And that's exactly what we want here. We don't want anything to last too long, but we don't want anything to start too slow or come on too slow. And so you do have other drugs in the class. You have pancuronium, you have vecuronium, you have cisatracurium or Nimbex. And all of these drugs are okay. It's just that their PK/PD profile, it just doesn't fit this particular scenario with RSI. And so I like the choice of drugs. They make sense. And it is important to know that when you give a person a paralytic, it does not treat pain. It does not sedate. I need people to understand that when you give a person a paralytic drug like rocuronium, it does not treat your pain and it does not sedate the patient. So you need to give your sedation first and then you paralyze. Okay, that's very important. And so ketamine for your induction sedation, both pre and post, and then you have rocuronium for your paralytic. And so this is very appropriate.
Monitor. Morrison's clear.
That's a lot more blood than expected.
He's probably anticoagulated for AFib. Check his medical record, see if he's on a DOAC. Standby with 4-factor PCC if there's a brain bleed.
All right, here's another scene, and I'm glad that they had this scene in quick succession, right? One after another. And so here you also hear that the physician, he noted that he has more bleeding than usual. And then you also hear the resident say that he's probably anticoagulated because she sees that this patient has AFib on the monitor. And that's very important in this situation here because AFib on the monitor would suggest that he maybe was getting treated for his AFib with an anticoagulant drug. And so this is very important. And so they don't know any history of this patient right now. So they don't know which agent he's possibly could have been getting treated with. So you have multiple different options, right? You have your VKA antagonists like warfarin, and then you have your DOACs, direct oral anticoagulants, like rivaroxaban, apixaban, or Xarelto and Eliquis. And then you also have the dabigatran. And so you have multiple options, but the standard of care for AFib prevention, secondary prevention, are DOACs. And so likely he was probably getting treated with a DOAC. But in this case scenario, we don't want to assume, we don't want to guess. We simply just don't know what this person was getting treated for his AFib. And so this is very important also. She said 4-factor PCC. Why is that important? 4-factor PCC is indicated off-label for this very specific situation right here. So depending on your hospital, they will have either Kcentra or Valfaxar. And Kcentra is the name of 4-factor PCCs or 4-factor prothrombic complex concentrates. And this drug is simply there to replenish your body's own vitamin K dependent clotting factors, also protein CNS. And what this does is that it rapidly makes your body stimulate its own clotting factor so it can produce a thrombus, essentially to stop the bleeding. And so this is very important also. Here, I really don't like the fact that she didn't provide a specific dose of the 4-factor PCC because dosing certainly matters in this situation. We don't want to overdose this patient. We certainly don't want to underdose this patient as well. And so you can dose Kcentra 2 ways. You can dose it with body weight, or you can dose it as a fixed dose regimen. And here, this patient has an intracranial bleed, and we don't know the actual anticoagulant that was used. And so I would have liked to see some sort of dosing, at the very least, a fixed dose, because you can certainly give a fixed dose without knowing body weight in this very specific situation. So I will have to deduct points just because, I'm a pharmacist and, drugs and dosing matters. And so the script writers, they got the correct drug right in this specific scene, but they just didn't provide any dosing. And so a pharmacist will certainly be here in the emergency department on standby for these specific situations because they never show us in shit like this. But we're very much there for shit like this. And so I do like this scene. I just don't like that they didn't provide specific dosing in this situation here. But I think it's appropriate.
50 fit, didn't touch her.
Did she faint or did she trip off the platform?
Nobody knows. The other guy jumped down, pulled her off the tracks just as the train was rolling in. Isolated injury to the foot.
The train ran over her foot.
Got caught between the platform and the incoming train.
Ma'am?
All right,
Ma'am, what's your name?
Fracture, 2 grams, Sepsis.
Do you speak any English?
All right, so I really do like this scene here, and I wanted to pause here as well. And I want people to actually pay attention to the background and what someone was yelling in the background. And don't pay attention too much on what's going on in the foreground right now. I want to focus your attention on the background. And someone was yelling out something very specific that I know is important. It's very, very situational context here. And so someone in the background was yelling type 3 open fracture. And this is very important. And this is also based largely off of the Gustillo-Anderson classification of open fractures. You do have type 1, type 2, and type 3 open fractures. And then your type 3 open fractures have further subsets, type A, B, and C. Just depends on the severity of the open fracture. But this is very important in this context here, and I don't want people to overlook it. So the guy said 2 grams cefazolin, right? This is very important because in open fractures, we're trying to significantly reduce the microbial contamination that the patient can experience by the time the surgeon makes the first cut. And so the thought behind it is we give prophylactic antibiotics in this situation in order to achieve therapeutic levels in the body and tissues before the surgeon actually makes the first cut. We're trying to target likely pathogens that lives on the skin and also can be multi-drug resistant depending on the type of open fracture it is and the severity. And so I didn't quite hear the dosing of the second drug that he named. He did say 2 grams cefazolin followed by something gent. I know the drug gentamicin, which is an aminoglycoside antibiotic, which again, this largely depends on your hospital's protocol for open fractures. The antibiotics of choice will differ, so there's no one standard of antibiotics. You know, some hospitals use aminoglycosides, some hospitals use piptazo or pipistrellin tazobactam, some hospitals even use clindamycin / meropenem. And so this really depends on your hospital's institution protocol and your hospital's local antibiogram and resistance rates. But the actual drug itself is very appropriate. Cefazolin being your first generation cephalosporin has very good coverage against those likely skin pathogens like streptococcus, right, staphylococcus, and things like that. And then depending on the type of fractures, usually type 3 open fractures and beyond, we want to add coverage against those gram-negative bugs and then those multi-drug resistant bugs as well. And so I do want people to go back and listen to this scene here and pay attention to what was said in the background. Type 3 open fracture, 2 grams cefazolin, and also gentamicin. Again, I couldn't quite hear the dose that was said, but the drug itself is very, very appropriate. I would say usually around 300 to 400 milligrams a dose because your aminoglycosides are based on weight based, so usually 5 milligrams per kilogram with gentamicin specifically, depending on the weight of the patient. And so, yeah, I really do like this scene here. However, in saying that, I do think they missed a key moment here, and they did not assess this patient for her tetanus, right? Because this patient have a severe trauma, a severe type 3 open fracture, they did not give her a tetanus shot to prevent her from having any sort of tetanus neurotoxin produced by the bacterium Clostridium tetani or tetani, however you pronounce it. And I think that's very standard in the ED, especially in large and severe trauma wounds like this. And so they did everything right as far as from a drug perspective, but man, they missed that tetanus shot, baby. That is super serious in this situation because this patient, she has a type 3 open fracture, severe degloving injury. You just don't know what type of bacteria are out there, and usually Clostridium tetani it's prophylactic against with the tetanus shot. And so, damn, I'm gonna have to deduct some points for this one, man. But other than that, this is a very good scene.
Otis Williams, healthy 31-year-old, VTAC arrest 2 weeks after triathlon. NSR with 1 shock.
Pulse 98, BP 110 over 60.
He's a little young for mine. Huh?
Exactly right. What's the differential, Dr. Collins?
Drug overdose, electrolytes, on QT, Brugada syndrome, WPW.
How you doing there, Otis?
Okay. What happened?
VTech again?
200 joules.
Charged and clear.
Back in sinus. Otis? Otis?
Oh, groaning's good. 5 of nasal O2 CBC, CMP, troponin, and D-dimer. What are you doing?
1 gram calcium glutamate, IV push.
We don't have the labs back.
Look at the monitor. Wide QRS and peak T waves, hyperkalemia.
All right, so here is a good cardiac arrest scene here, and I really do like this scene. However, of course, I'm a pharmacist here, and then everything I have to do is judgment based on the drugs given, right? I don't want to go into too much detail about everything else, but I want to make sure that people understand why drugs are given. And so here you see that the physician, he is trying to make the clinical diagnosis of hyperkalemia along with rhabdomyolysis based off the clinical scenario, what's going on right now, and the history of the patient given he just ran a triathlon. And so he's not informing the rest of his team of his thought process or anything like that. And then the first drug that he reached for to treat the suspicion of hyperkalemia is calcium. Okay, notice that he said calcium gluconate. Now, calcium comes in several different forms. They can come in calcium carbonate, calcium gluconate, calcium acetate, and then calcium chloride. So calcium has so many different salt forms, but he specifically chose calcium gluconate. And this is important. I don't like this scene just for the dosing reasons, simply because this is a cardiac arrest patient because of his likely hyperkalemia, because of the peak T waves on the EKG. But the reason why I don't like it because it's slightly not accurate, right? It's slightly off. And the reason is because typically in a crash cart, it's calcium chloride that's giving, not calcium gluconate. Now, he maybe was like in the heat of the moment while shooting this scene and just forgot to say calcium chloride. Instead, he said calcium gluconate. And then he said 1 gram calcium gluconate. Now, to a patient who is not in cardiac arrest, right, 1 gram calcium gluconate will be sufficient enough. But in this specific case, this patient is obviously unstable and he just had a cardiac arrest. And so typically in a crash cart consists of calcium chloride in a readily available syringe. It's usually 10% calcium chloride in a 10 milliliter syringe. And so with this, he's supposed to say calcium chloride, not calcium gluconate. And then if you were to give calcium gluconate in this situation in a crashing cardiac arrest patient, you typically would give either 2 or 3 grams of calcium gluconate, not 1 gram of calcium gluconate. And that's because calcium gluconate is 3 times less potent than calcium chloride. Calcium chloride is 3 times more potent and has 3 times more elemental calcium than calcium gluconate. And so in this situation, the drug is correct. It's just that the specific salt form, it actually matters in this situation. And we will certainly use calcium chloride here over calcium gluconate because this patient is in a cardiac arrest right now. And so we need all of the potency of the calcium chloride to stabilize that cardiac myocyte. And that's essentially what the role of calcium is in treatment of hyperkalemia. The role is to stabilize those cardiac cells. Calcium here, think back to those action potential phases, right? In the cardiac electrophysiology, you have phase 4, phase 0, which is your influx of sodium, phase 1 and phase 2, which is your plateau phase, right? Your plateau phase is created by a efflux of potassium and an influx of calcium that creates that plateau phase. And so in this situation, there's too much potassium buildup in this patient where it's causing significant disruption in the patient's heart electrical activity, which is causing this dysrhythmia, which causes the patient to have a cardiac arrest. And so with this scene here, I love the drug, but the actual dose and the actual salt form of calcium is not correct. And calcium gluconate, it does come in a pre-filled vial, but not a pre-filled syringe, right? Calcium gluconate does come in vials that you have to manually draw out, but it does not come in a pre-filled syringe. That's calcium chloride that's used in a crash cart in this situation right here. So the execution is not 100% as far as the dosing and drug perspective, but the overall treatment approach is exactly spot on to treat such hyperkalemia. So this scene is very, I would say, an 8 out of 10.
QRS is narrowed. Much better.
Potassium is 7.7, creatinine 5.6.
High potassium and renal failure. Just what you thought.
Must be my lucky day.
Ordering 10 units of regular insulin and 25 grams of glucose.
And so, yeah, you see that the physician, his call was correct. As far as the situation going on, they just gotten the rapid labs back, and then his potassium was over 7.5. His creatinine was also very, very high. And so what this tells us is that the patient indeed was suffering from rhabdomyolysis because of his triathlon. His kidneys were not able to clear those myoglobin and that potassium, and so it built up, causing lethal arrhythmias. And so here you hear the resident say, start 10 units of insulin, right? And it's very important to know that she wants to start 10 units. That's the standard dose of insulin as far as what you would start a patient on to treat hyperkalemia, to see how the patient responds. And you hear her say, also give 25 grams of dextrose. And that's very important here as well, simply because dextrose is used to counteract insulin. Insulin will always, 100% of the time, drop your blood glucose levels or your blood sugar levels. It will drive potassium back into the cells as it's supposed to, treating the hyperkalemia, but in doing so, you will cause a significant drop in a patient's blood sugar levels. And so therefore, we usually typically give dextrose in combination with insulin when we're treating hyperkalemia.
Sir, 79, fever and cough from assisted living. He has a history of mild Alzheimer's. 1, 2, 3.
Heart rate 130, BP 90 over 60. Gave him 500 cc's normal saline.
Hi, Mr. Spencer. I'm Dr. King. This is Dr. Collins. How are you feeling today?
Is it dinner time? I'm not really hungry.
Do we have any paperwork from the facility?
He has a pulse. IV fluids and medications are fine, but no intubation and no chest compressions.
That's helpful.
Course Ronchi here.
Right middle lobe infiltrate.
Temp 102. Call a code sepsis.
Code?
To make sure we check all of our boxes, the federal government audits our sepsis bundle performance and publishes the data online. Today, it better be perfect.
2 sets of blood cultures, lactic acid, 30 cc's per kilo NS, a gram of ceftriaxone, 500 of azithromycin, repeat lactic, then 3 hours.
Nice.
All right, so here is a scene where I don't really like it that much, specifically for drug reasons. Of course, again, I'm a pharmacist. I have to explain to you guys why drugs matter. And I think they missed a lot of key elements here in this particular scene. And so we have a gentleman here, an older gentleman. He's brought in by an assisted living. And to me, that already raises concern about the potential pathogens that can probably, they can harbor a lot of those super gram-negative resistant bugs. And so to me, that raises suspicion. And what they did here is that they started him on the empiric CAP treatment. CAP as in community-acquired pneumonia. And so this gentleman, by definition, has a community-acquired pneumonia that was brought in from the outside into the hospital. And so his severity isn't that severe because he is not intubated, nor is he sedated requiring vasopressors. So by definition, he has a mild to moderate CAP. And so they are treating him as such. And to me, depending on your hospital's protocol, your hospital's antibiogram, your infectious disease personnel, both pharmacists and physicians, this scene can be treated so many different ways. Antibiotics can be given so many different ways. And so there's no standard treatment approach with this sepsis bundle giving this patient's presentation. And so the drugs that she chose are okay as far as the standard CAP treatment. The standard CAP treatment is simply your beta-lactam plus a macrolide in patients with comorbidities. And so this patient is in the hospital. And so I would have liked to start him on broader coverage simply because he came from an assisted living facility. They are known to just harbor a lot of those gram-negative resistant bugs. And so for me, I probably would have started him on something more broad just to cover my bases. I'd rather go big and then de-escalate later when I have to, when I know my cultures and sensitivities. And so the reason they didn't do a good job here is because from a drug perspective, the thoroughness, they did not do a good job of assessing this person for additional risk factors. Risk factors for MRSA or MRSA. They did not do a PCR nasal swab to detect if this patient has colonization or contamination. And so they did not do a good job of additional pseudomonal risk factors, right? We just don't know any risk factors that's associated with this patient. The only history that we know here is that he has a mild Alzheimer's, which is fine. But to me, when I look at this clinically, I just have a hard time believing that this patient, an older gentleman, has never just been in the hospital, especially within the last 90 days or within the past recent year. And so you hear the EMS person, she said that he did have IV medications, not antibiotics, but they could be antibiotics. She just didn't specify. And so to me, they could have specified which previous medications were he on or is currently taking. That could have gave us more insight on what to determine the treatment is. And so what they're trying to display is what's called sepsis. And this is largely based off of the Surviving Sepsis campaign. A lot of hospitals get audited with this yearly, along with their stroke bundles, their STEMI bundles. This is very standard, the standard sepsis treatment. He's already received 500 cc's of normal saline from the EMS people, and she's already given him another 30 cc's per kilo of NS. Again, I probably would not have chose normal saline. It's recommended to choose balanced crystals, something like plasma-like or lactated ringers, simply because normal saline can cause your metabolic acidosis because of the chloride content in normal saline. And so other than that, everything else was cool as far as the approach. The drugs that she chose is standard for CAP or community-acquired pneumonia. Your beta-lactam and your macrolide are your standard CAP treatments for patients with comorbidities. And so she chose ceftriaxone 1 gram, and that's okay, that's appropriate. So the dosing falls within the recommendations given though this patient's weight. And then so the reason she chose ceftriaxone is because ceftriaxone is your 3rd generation cephalosporin. And that is typical, and it covers a lot of those likely pathogens that will cause or have a likely high suspicion of causing CAP. So think your streptococcus, think your Haemophilus, things like that. And so ceftriaxone, it has a good PK/PD profile where it does not rely heavily on renal elimination. And so this means that you can dose it once daily. You can give it to patients with renal insufficiencies. And so that's why ceftriaxone is good in this situation. And beta-lactams across the board have a relatively good, safe side effect profile. And so that's the reason we give ceftriaxone a 3rd generation cephalosporin. The reason why she chose azithromycin in combination with ceftriaxone is because your azithromycin covers your atypical pathogens, those pathogens that ceftriaxone does not cover. And so we're talking, think your Legionella, right? Think your Chlamydophila pneumoniae. And so things like that. And so azithromycin, again, doesn't rely heavily on renal elimination, so you don't really have to worry about renal clearance. And so azithromycin, relatively good side effect profile compared to your other drugs that covers atypical pathogens. And so the only caveat with azithromycin is just a lot of drug-drug interactions, also QT prolongation. So I probably will caution in giving this to people with pre-existing heart diseases because it can cause QT prolongation if your patient is receiving other drugs that can cause QT prolongation as well. And so that's your standard treatment. However, for this patient, again, he came from an assisted nursing facility. We don't know any additional risk factors that they did not screen for. No PCR screening for MRSA, no pseudomonal screening. We don't know this hospital's local antibiogram specifically for the ER. We don't know any resistance rates. We just don't know if this patient even been in the hospital recently in the past 90 days. I have a hard time believing that he just did not come to the hospital in the past 90 days or within the past year for that matter and haven't gotten treated with IV antibiotics. So for me, I wanted to start broad. I would have started broader just to cover my bases, to cover MRSA, to cover Pseudomonas, and then de-escalate it when I have cultures back, when he's more stable, he doesn't have a fever, etc. So for me, depending on who you talk to, who your hospital's infectious disease personnel is, both pharmacists and physician, this scene can be handled in so many different ways. But overall, I think it's like maybe a 6 out of 10. As far as a drug perspective, we probably wouldn't give normal saline. We will give probably lactated ringers or plasma-like, something more balanced and not normal saline because of that hyperchloride content. And so with that, I think it's appropriate. This patient, they were trying to display, like I said, sepsis, systemic inflammatory response. This patient had 2 out of the 4 SIRS criteria. I really hate SIRS criteria. It's not very specific. It's really fallen out of favor. And so he had a fever. He had a new coursed rhonchi. He had a new right middle lobe infiltrate on chest imaging. And then all of these are telltale signs of your typical pneumonia. And so I think this scene was okay. I just think they could have handled it differently. So, all right, guys, that is it for me. I know I've talked so long, and you can see, you see this here? This is my virtual gaming setup, and so every time someone likes the stream, comment, subscribe, or anything, donate, the tip jar will fill up. And so I suspect I really would like for people to, subscribe to the channel, show some love, and then I want to get that tip jar full for you guys. And so with this, I think overall, this is a very good series. However, they are missing some very, very minute details that has a drastic impact on patient care as far as drug therapy is concerned. And so I probably will give this first episode maybe a 7 out of 10 because, again, from a pharmacist perspective, they just missed a lot of things that I would like to see get implemented. And I know this is a 40-minute show. You can't possibly show everything, but in reality, they certainly miss a lot of these things. But I'm going to start working on episode 2, and so I will get it out as quickly as I can with my time allotted with my schedule. And so yeah, if you guys have any questions from a pharmacy and a drug pharmacology perspective, feel free to holler at your boy and just shoot whatever question you have in those comments. And so yeah, holler at your boy.